Rhay is a sterile inflammatory synovitis, occurring within 4 weeks of an infection elsewhere in the body, primarily urogenital or enteric infections. The arthritis is typically an asymmetric oligoarthritis that predominantly involves large lower extremity joints. The causative organism cannot be cultured from fluid in the joint cavity, however in recent years it has been shown that antigens of the triggering microbe can be detected in the synovial fluid or synovial tissue of the affected joints. Rhay patients are frequently HLA-B27 positive and commonly exhibit systemic symptoms with unique extraarticular manifestations including skin, eye, and enteropathy features. As originally described in 1916, Reiter's syndrome is the clinical triad of conjunctivitis, non-gonococcal urethritis, and arthritis following infectious dysentery. For many years, Rhay and Reiter's syndrome were used as synonyms. This term is no longer used due to Hans Reiter's participation in Nazi medical experimentation during World War II. The triad is now considered to be a subset of Rhay because 2/3 of patients do not have all three features. Susceptibility to Rhay may be conferred by the specific class 1 major histocompatibility antigen, HLA-B27. However, the development of Rhay is strictly dependent on infection with certain organisms predominantly acquired through mucosal surfaces, enterogenic or urogenital. In hospital-based reports, HLA-B27 is present in 60% to 80% patients with Rhay. These patients tend to have more severe arthritis, extraarticular manifestations, higher prevalence of sacroiliitis, and a protracted course. Notably in population-based studies, patients with Rhay are less likely to be HLA-B27 positive, 30% or less in some ethnic groups. These cases have a milder oligoarthritis with fewer systemic symptoms or extraarticular manifestations. Role of HLA-B27 in Rhay pathogenesis. There are several hypotheses to date. 1. Misfolding hypothesis. HLA-B27 folds more slowly than other HLA types when assembled in the endoplasmic reticulum. This may cause inadequate folding and instability of HLA-B27, leading to accumulation of such molecules with activation of inflammatory processes. 2. Arthritogenic peptide hypothesis postulates that HLA-B27 on antigen-presenting cells present microbial peptides that may mimic certain self-peptides, molecular mimicry, to CD8 cytotoxic T lymphocytes, leading to autoimmunity. 3. Heavy chain homodimer hypothesis. HLA-B27 can be expressed on the cell surface as a homodimer of heavy chains without Cis-2 microglobulin. These abnormal chains can activate natural killer T and B cells. Other potential factors involved in the pathogenesis of Rhay. Since patients who are HLA-B27 negative also develop Rhay, other focus of investigations favors the role of microbial factors. Some examples of these theories are the ability of certain outer membrane proteins of some of the involved organisms, Salmonella, to stimulate specific interleukin, IL, responses, IL-17 and IL-23, in synovial cells, finding metabolically active particles, chlamydia, in the synovial tissue of patients with chronic Rhay, and alteration of the gut microbiota leading to an abnormal immune response. Infectious agents trigger Rhay. Urogenital, Chlamydia trachomatisa, Uriplasma ureolyticum, Mycoplasma genitalium, enterogenic, Salmonella, Typhimurium, S. enterotitis, S. Heidelberg, S. cholerae suis, Shigella flexneri, S. dysenteriae, S. sonnae, Yersinia, especially O3 and O9Y pseudotuberculosis, Campylobacter jejuni, C. coli, Clostridium difficile, Escherichia coli, diarrhogenic strains, Giardia lamblia. Respiratory. Chlamydia pneumoniae, group of beta hemolytic streptococcus. Viral. Human immunodeficiency virus. Multiple sources. Case. Reports only. Helicobacter pylori. Vibrio parahemolyticus. Mycobacterium bovis. Calmette-Guérin bacillus. Klebsiella pneumonia. Strongyloides stercoralis. Note: in up to 40% of Rhay patients, an infectious agent cannot be identified. Serologic tests especially for chlamydia may identify a previous infection if cultures PCR are negative. Who gets Rhay? Primarily young adults aged 20 to 40 years. Patients with enterogenic Rhay exhibit higher relative risk for women than for men, 1.5. 1, whereas those with the urogenital form are predominantly men. Rhay is rare in children and less common in African Americans. Rhay is one of the most common types of inflammatory arthritis affecting young adult men. After the initial infection, when do symptoms of Rhay first appear? Although the initial infection may be mild or inapparent, 10%-30%, most patients will develop systemic symptoms within 1 to 4 weeks. 2 cutaneous lesions are characteristic of Rhay. Circinate balanitis and keratoderma blennerigicum are relatively specific for Rhay. Circinate balanitis is a painless, serpiginous ulceration of the glans penis. Similarly, keratoderma blennerigicum refers to psoriasiform lesions occurring primarily on the plantar surface of the heel and metatarsal heads. Both lesions are predominantly associated with urogenital Rhay, chlamydia, and resolve spontaneously. Musculoskeletal manifestations of Rhay. Arthritis. In Rhay, the joints tend to be moderately inflamed and characterized by prolonged stiffness. Joint involvement is typically asymmetric, oligoarticular, less than 5 joints, and confined to the knees, ankles, and feet. Large joint effusions, especially in the knees, are not unusual. Hip involvement is rare. Upper limb arthritis, e.g., wrist and digits, may also occur, 50%, but is never more prominent than the lower extremity arthritis. Uncommonly it can be a polyarthritis. The arthritis always lasts over 1 month, though usually longer. Joint erosions may result from chronic disease. Enthesitis. An inflammation of the ligament, tendon, joint capsule, or fascia insertion site into bone, enthesis. In Rhay, enthesitis commonly causes heel pain, Achilles tendon and plantar fascia, metatarsalgia, plantar fascia, and iliac spine, crest pain. Enthesitis are common in Rhay, and may help distinguish it from other. Differential diagnosis. Dactylitis. Sausage, digits of fingers and toes are due to a combination of arthritis, enthesitis, and tendinitis. Sacroiliitis, spondylitis. Up to 40% of patients with Rhay may have axial skeleton symptoms, and 25% develop radiographic changes. The risk of developing sacroiliitis and/or spondylitis is related to disease chronicity and HLA-B27. The extraarticular manifestations associated with Rhay. Constitutional. Low-grade fever. Weight loss, rare. Ocular. Sterile conjunctivitis, 35%. Anterior uveitis, 20%, acute unilateral. HLA-B27 positive. Gastrointestinal. Infectious ileitis, colitis. Sterile ileitis, colitis, 60%. Cardiac, rare and acute disease. Heart block, 1%. Aortic regurgitation. Aortitis, 1%. Pericarditis, rare. Genitourinary. Infectious urethritis. Sterile urethritis. Prostatitis. Hemorrhagic cystitis. Salpingitis. Vulvovaginitis. Mucocutaneous. Cercinate balanitis, 30%. Most frequently associated with chlamydia, keratoderma blennergicum, 15%, hyperkeratotic nails, 10%, painless oral ulcers, 25%. Erythema nodosum, Yersinia. Renal. IgA nephropathy. Renal amyloidosis. Other. Thrombophlebitis. Livedo reticularis. Neuropathy, cranial or peripheral nerve.